Hi, this is Ms. Mastrada. We're going to go over the total parenteral nutrition slides. So the definition, it's a solution with concentrated nutrition to provide adequate nutritional support to a client who cannot maintain nutrition through oral intake or tube feedings. We're going to discuss the principles, administration, complications, and nursing management of the patients receiving central and peripheral parenteral nutrition. So when we talk about TPN, also known as CPN in your books, central parenteral nutrition, because it has to go through a central line. TPN goes through a central line. We talk about the components. So let's talk about the components of TPN. So it's sugars, amino acids, fats, electrolytes, minerals, trace elements, and vitamins. So the way that I want you to remember that is MADE TV, MADE-TV, MADE TV. So minerals, amino acids, dextrose, electrolytes, trace elements, vitamins. Electrolytes, vitamins, and trace elements are going to be per orders. They're going to take blood from these patients every day, and they're going to mix it up depending on what that patient needs that day. Calories are primarily from the dextrose and the fat emulsion. Proteins in the form of amino acids. So think about a normal healthy adult. We need 45 to 65 grams of protein daily. But think about your patients that are in the hospital or sick. They need 1 to 1.5 kilograms or grams per kilogram per day. So the patient, no, I'm sorry, we need 1 to 1.5 grams per kilogram per day. A patient in the hospital, though, might need 1.5 to 2 grams per kilogram per day. So, and your burn patients might need even more. Your patients' bodies are healing or trying to heal or fighting something off. They're going to need more calories than we need on a regular basis. So types of patients that we see with TPN. So your patients that somehow, for some reason, can't feed their own gut. So you have your hyperemesis gravidarum. So those are those moms, pregnant moms that are just sick, and they can't get anything down. They're just vomiting. Or your patient with intestinal obstruction. So we can't put an NG tube in even to give them anything, right? So we have to give them something through their veins or arteries so that we can give their intestines time to heal. Or if they just had surgery, time to heal. Your patients sometimes with anorexia nervosa, we will use it. I used to work at a psych hospital. We used to do NG tubes, but I guess, in some cases we might use TPN. Patients that have cancer that has caused some sort of obstruction or the radiation, they're just really sick from the radiation or chemotherapy. They also are going to need TPN. And then just critically ill patients, you might have an older, frail woman who is still eating orally, but the amount that they're eating isn't covering their caloric needs in whatever situation they're in. So we might have to also give them TPN. Delivery method, again, TPN or CPN has to go through a central line. And this is because the amount of dextrose is actually caustic to the veins, will cause infections. So the place where we're putting it into, it's going into a central line, which goes into that superior vena cava. The turbidity is so high there that it doesn't just sit around. It just immediately is just moving. So the patient doesn't have any ill effects from the TPN. We have to use a pump, and we have to use a special tubing extender that has a filter in it. Complications, infections, again, if we're putting something into a line that's too small, the dextrose is so high that it's going to cause infections, it causes bacterial growth. Or if for some reason the TPN gets bacteria in the bag. So we never, ever, ever add anything to the bags. The pharmacy does it all under a sterile hood. We don't ever add anything to the bags. We also never use the tubing for anything else. We don't use the ports to give anything. That once TPN is plugged in, we leave it there, it's closed. We can have metabolic complications. So the hypo and hyperglycemia, and we'll talk about how we prevent those. And that's going to be if, let's say the patient's getting TPN and you run out of TPN and the next bag's not up there yet and you just stop it. Your patient can go hypoglycemic. They can get altered renal function. They can have vitamin and trace element deficiencies. We can get fluid and electrolyte imbalances, refeeding syndrome. So refeeding syndrome is fluid retention and electrolyte imbalances that happen after usually long-term malnutrition. So chemo patients, ETOH patients. Mechanical, they all happen during insertion. So, your air embolus, your hemo, your pneumo, your hydrothorax. We can get hemorrhaging in the area where the CVAD is, and then thrombosis. Your nursing care is going to change depending on what's going on with your patient. But let's say your metabolic complications, so your patient is hypo or hyperglycemic. So to prevent metabolic complications, we want to start slow and titrate up. So we never just say, oh, this patient needs TPN, we're going to start them at 60 cc's per hour. We want to start low. So we might start them at 20 cc's per hour and work our way up to the 60 to prevent the hyperglycemia. Same time, you run out of that TPN or you get a DC order, you don't want to just stop it. So if with TPN, you do run out before the next bag comes, your emergency stop hang is your dextrose 10%. So you always, again, want to make sure that you have a pump and a line with a filter. You also want, when you get that bag from pharmacy, to check your bag for any contaminants. Does it look cloudy? Does it have anything floating in it? Does it just look weird? You want to make sure your bag is kept refrigerated. You can take it out half an hour or so before just to warm it up a little bit. Again, we're never adding to the bag or tubing. We're never drawing blood from that same line. We want to make sure that when we get it from pharmacy, you'll get it and you'll have an order on the chart that tells you what should be in it. And you want to make sure that the bag and the order are verified that they're the same. As far as the dressings on those CVADs, remember, we're making sure that we're changing them per protocol or as needed. That bag of TPN and the tubing has to be changed every 24 hours. So let's say last night it was changed at 6 p.m. You're at the end of your shift and your new bag is there. You have to make sure that it's changed by 6 p.m. It cannot stay up longer than 24 hours because of the bacteria growth. The tubing also has to be changed every 24 hours. Your patients that have TPN are going to be getting AccuChecks. Usually it's every 6 hours. So maybe noon and 6 and then midnight and 6. It's going to be covered with sliding scale insulin coverage. You're never going to use that morning's labs to cover. You're always going to get a finger stick right before you cover with the insulin. And usually their glucose is going to be a little bit higher. This is high dextrose TPN. We want to make sure we're getting daily weights. We want to make sure we're not overloading our patient with fluids, that they're, outputting the equivalent of the input, that, they're not holding on to the fluid. And then obviously we want to monitor the I's and O's. And then we have PPN. So this is your peripheral parenteral nutrition. So this is going to go through a peripheral IV. It's usually short-term use, 7 to 10 days. So again, maybe your patient just had some bowel surgery and they're going to keep them NPO for 3 days. they might give them PPN for 3 days. So that way they can still get what their body needs to heal without disrupting what's going on in the gut. The protein and calorie requirements for these patients aren't as high usually as we need for the TPN. Most of them, unless they have a gut issue or a bowel issue, we have them supplement with PO intake. The difference with the PPN to the TPN is if you run out or need to stop it for some reason, you're going to do dextrose 5%. The dextrose is not as high in the PPN, so 5%, whereas the TPN was a 10%.